posted on the BC website so that you can go back to it, refer to it, or send it to your friends and family. Next slide. So I want to acknowledge on this dark and spitting, raining morning here in British Columbia that we're hosting this session on the unceded and ancestral territory of the Coast Salish peoples. That includes the territories of the Musqueam, the Squamish, the Tsleil-Waututh nations, and the Métis Charty community of the Lower Mainland. And as always, we continue to remember and think about how we can best support the land and the peoples on it going forward in the spirit of truth and reconciliation. Next slide. So Province-Wide Rounds is a collaborative enterprise from the University of British Columbia Division of Nephrology, as well as BC Renal. We thank all of our corporate sponsors and all of you and the different health authorities to make this a successful and meaningful educational and endeavor to improve the care of patients living with and at risk for kidney diseases. Next slide. So it's with great pleasure that I introduce Dr. Michael Walsh, who received his medical school internal medicine nephrology training close to us here at the University of Calgary in Alberta. He then completed additional training in vasculitis and lupus at University of Cambridge, UK as a Crescent trainee, followed by a CHR RCT mentoring fellowship and PhD at McMaster University, where he was involved in studies of perioperative care and acute kidney injury. He's now on staff and the director of the Glomerular Disease Clinic at St. Joseph's Healthcare in Hamilton, an associate professor of medicine and health research, and a member of the Health Research Methods, Evidence, and Impact at McMaster University. He's a senior scientist at the Population Health Research Institute and the provincial medical lead for person-centered care for the Ontario Renal Network. And his research interests include almost anything that involves kidneys and the complications of people who suffer when their kidneys fail. So in that spirit, I'll turn it over to you, Mike, for an update on ANCA-Associated Vasculitis. So over to you, and thank you for making the time. And sorry that we couldn't get you physically out here, but this is next best. Over to you.
Thanks so much, Adira. I'm going to try and share my screen here. I don't know if this works. That's did that show up?
Yep, it did.
Perfect. Okay, well, thank you so much for the kind invitation to come out and speak. It really is a pleasure. I do wish I could be there in person, although slightly less so after Adira's description of the weather, because I can see the sun shining out of my window here. So I'm going to talk about plasma exchange and glucocorticoids and similar things, all in the context of ANCA-associated vasculitis. These are my disclosures. There's a lot, but I don't take any money. If that helps you feel better about the number of folks I work with. I am supposed to disclose for the Royal College that, in fact, prednisone is considered off-label in this indication, which is kind of funny. So I'm going to talk a little bit about why ANCA-associated vasculitis is important and what it is. I'm going to talk a fair bit around plasma exchange, and I'm going to try and make some sense of how we apply the current evidence to treating the patients that we see. And then I'm going to talk a bit about prednisone, how we dose it, Avacopan, whether or not we're giving both, neither, or some combination thereof. I've got it in smaller print because I realized as I was putting the talk together that I've got way too many slides and that I tend to ramble on. So I hope that I've hit the right emphasis for this. If at any point you go, you're dragging on, Mike, move it along, feel free just to yell at me and I will re-emphasize the prednisone part. And I'm going to apologize in advance that I'm just getting over an infection. And there is the mild possibility that I'm going to take a time out to go cough excessively. I will try and mute myself before I do that, but please do excuse me if that happens. So what is ANCA-associated vasculitis? You know, it's part of an entire grouping of autoimmune diseases that result in inflammation of blood vessels. We, I think, have a particular love for ANCA-associated vasculitis in nephrology because it's one of the most common of the vasculitides that we'll ever see. We do tend to really concentrate on two entities under the ANCA umbrella. which is microscopic polyangiitis and granulomatosis with polyangiitis, or formerly Wegener's. We tend not to talk so much about eosinophilic granulomatosis with polyangiitis just because the renal involvement is less common, but also as a disease entity, it's got a different natural history, different treatments, different responses. And so today, for the purposes of this talk, when I say ANCA or AAV, I'm really just talking about MPA and GPA, and I'm not going to really differentiate between them too much, except maybe perhaps in a couple of specific circumstances. I think for the clinicians, though, this is what ANCA is all about, and it's certainly part of what made me fall in love with treating patients with this disease, is that it's so complicated. It can show up as almost anything. And as Adira was going through my CV and saying that I love all things kidney, I was thinking I actually love all things medicine. And I think that's why I gravitate towards diseases like AAV so much. You've got on the left-hand panel this thing called the BVAS, which is really an academic tool, but it's a nice little checklist of many of the different manifestations that you can see. On the right-hand panel, you have a nice Nature Review article that goes through various different organ manifestations, and you can see things like the saddle nose deformities in the top left. Below it are lung nodules, and below that are some of the renal manifestations. In particular, in the middle bottom is the necrotizing glomerulonephritis that we see with ANCA-associated vasculitis. And we think that actually happens in about 3/4 of all patients who have ANCA-associated vasculitis. And of those 3/4 who have kidney involvement, I would say that about 3/4 of those have what we would typically call nephrology kidney involvement, where there is at least modest impairment, if not more severe impairment, of kidney function to go along with an active urine sediment. Now, I put this up just because things have been changing. So this is kind of what the diagram looked like 20 years ago when I started developing an interest in ANCA-associated vasculitis. And we knew there was ANCA, and we were pretty confident that they could be bad, although we weren't too sure. We didn't have a whole lot else other than that neutrophils were probably the effector part of the immune system that was doing a lot of the damage. More recently, however, this diagram is becoming increasingly fleshed out. I have sadly had to learn many things about complement that I thought I could safely forget years ago. But there's also lots of new things like NETs down in the bottom and NETosis, lots of new things around IL-17 and TH cell replication and maturation, and dendritic cell presentation. So there's lots of new ways in which we're starting to understand ANCA-associated vasculitis. And I think it's actually really exciting. And you can say this, generalize this to a lot of nephrology right now, is that our understanding of our diseases is improving, and that's leading, hopefully, to increasingly complicated but newer and more interesting treatments for our patients as well. But despite these advances in understanding, this is still an important disease to think about how we treat and how we optimize treatment. This is now an old slide where we've divided out patients with ANCA-associated vasculitis that either have, again, some substantial kidney involvement at the beginning of their diagnosis with GFRs of less than 50, or not too substantial. And we see that, in fact, those with a bit of kidney involvement, or even sometimes a lot of kidney involvement, have very high risks of either developing kidney failure or of passing away within the first year. A lot of that very sharp decline in the graph is due to the non-recovery of acute renal failure, and that really sets people up for poor outcomes. In fact, if we look at that first year mortality, only about 1/3 of it is due to ANCA-associated vasculitis now, and we more directly attribute about half of it to infection. And granted, those two things get interwoven a little bit because our response to ANCA-associated vasculitis and its recurrence or its refractory nature is increased immunosuppression, which often is what sets people up for infection. But it is no longer a disease that is most likely to kill you. It's the treatments that are much more likely to kill you. Again, I say that slightly tongue-in-cheek because it is also likely that people who come with autoimmune disease come with a natural immune deficit that leaves them potentially set up for infections as well. So I think it's important to ground ourselves in the kind of patients we see. And again, one of the beauties of ANCA-associated vasculitis is that we see a huge diversity of patients. It's a very heterogeneous population. So I put here two typical cases, both of whom have weight loss and arthralgias for a period of time before their diagnosis. One who is coughing up some blood, the other one who isn't. one who has fairly significant renal involvement with a creatinine of 425, and one who doesn't have much substantial kidney involvement with a creatinine of 88, but clearly a significant lung hemorrhage. They're both MPO positive. One is hypoxic on room air, and the other isn't. We're going to come back to this in a little while when we try and develop some relevance around the treatments. So this is a slide that I put up typically for our fellows, but this is all you really need to know about treatment. I've highlighted at the very top that these are the induction regimens, or the so-called induction regimens, as I think the lines are blurring. But they involve rituximab, IV cyclo, or pulse cyclo, or oral cyclo, and for varying doses and dose regimens and numbers of or duration of therapy. In the end, amongst those many treatment options that we now have, there isn't a lot to differentiate them in terms of efficacy. Mostly what differentiates them is their risk of serious side effects. And in Canada, of course, we'll always have to talk about accessibility and availability. And a lot of what drives our choices is really around accessibility, availability, and the risks of specific serious side effects of these medications. Now, the talk would have been really too long if I went into any of this. So we're going to skip over that now and just say that those things all are pretty effective agents, and which one you choose will really depend on the patient in front of you and the risks of the medications that are acceptable or unacceptable. So instead, we're going to skip down to plasma exchange, so this bottom part. You can see there I have a select cases, so we're going to try and figure out how we get to select cases. I love plasma exchange, but really, it's been like a therapy that's been looking for a disease to treat for a long time. And it's been passed around from antibody-associated disease to antibody-associated disease with kind of modest believability and effect. This is somewhat actually, I think, now reflected in our guidelines that as of 2020, they still differed pretty substantially. So you can see KDIGO, our major kidney guidelines, saying that it should be considered in any patient who has life-threatening or organ-threatening disease with a creatinine greater than 500, as well as anyone who has diffuse alveolar hemorrhage with hypoxemia. And converse to this, the ACR recommended against routine use in any disease category. EULAR said consider if life-threatening with a creatinine of greater than 300, but don't consider in patients with diffuse alveolar hemorrhage. And the apheresis guidelines came out and said it's just accepted therapy in rapidly progressive GN and in DH, and go for it. So how did this all come about? Well, I think first of all, just consider how might plasma exchange actually work. We mostly say that it's likely along the removal of autoantibodies. And in fact, the story around whether or not ANCA are pathogenic in and of themselves has probably gotten a little bit stronger in the last decade. But there is lots of other potential ways in which plasma exchange works. I always find it actually kind of shocking how little we know about what plasma exchange is really doing. It's kind of like IVIG. We put some of the magic in and good things seem to happen, but we're never sure just how good or long-standing the goodness is. And so I've listed out some other things there. My favorite is the bottom one, altered immune function, which I think is really a reflection of how little we know about immune function in general, but we think it's good. In Canada has a very long and proud history in this field. One of the largest trials at the time was done back in the 1990s, the early 1990s, late 1980s. It involved 32 patients. And they found that there was a neutral effect of adding plasma exchange on to standard of care compared to those that didn't have a plasma exchange added. Neutral in terms of both the level of creatinine that patients were getting through their treatment at and whether or not they were dialysis dependent. Interestingly, they did actually identify that there was a larger number of infections and deaths in the plasma exchange group, which was very precocious of them, looking more than just kidney function at the time, wasn't very in vogue. And so seeing that there were these other trends of potential consequences was really important. At the time, they made a pretty bold statement that it's highly unlikely that a larger study would demonstrate a significant benefit of plasma exchange. I think that also is reflective of the era. 1990s, small trials, particularly in rare diseases, was considered about as much as we could do, but that has obviously been changing. And in fact, a few years later, MePEX came out that gave a lot more credence to the idea that plasma exchange was in fact useful and helpful in patients with severe ANCA-Associated Vasculitis. They enrolled 137 patients, so roughly 5 times the number of patients that were involved in the Canadian trial. They recruited those only with creatinines of over 500 or who required dialysis at their diagnosis. And then they randomly assigned them to either plasma exchange or IV Solu-Medrol. And you can see in the right-hand panel that that dashed line, or the little pluses on it, is the plasma exchange group who required dialysis after treatment far less frequently than those who did not receive plasma exchange and received methylprednisolone instead. That looked really encouraging. But even at that time, there was a comment that there was a lot more death than was anticipated. And we said, well, really, how often is it in nephrology that you expect a decrease in the risk of end-stage kidney disease without there being some benefits in terms of survival? And so as a fluke of chance, I happened to be looking over the shoulder of the person who was writing the report, and we were looking at longer term follow-up data, and we noticed that, in fact, death was going the wrong way most of the time, that there was a slightly higher death count in those who had received plasma exchange and those who had received IV methylprednisolone. We thought about the composite of end-stage kidney disease and death. It looked pretty neutral. End-stage kidney disease itself actually looked like it was still maintained out for a long period of time. But the mortality signal was also maintained for a long period of time. We did not really understand why. We synthesized that data into meta-analysis, and it still came up as favoring plasma exchange over control. But again, as the composite was used, it didn't look so favorable, and it was not quite clear why that would be. And so we designed a follow-up study called PEXIVAS that was published back in 2020. You may have missed it because it came out at almost the exact time when the lockdowns for COVID happened. But the way that we designed PEXIVAS was that we tried to answer 2 questions. We wanted to know whether or not plasma exchange reduced the composite of death and end-stage kidney disease. And again, that's because we thought that it may actually reduce end-stage kidney disease, and we thought that there should be a benefit in terms of mortality as well, and that perhaps previous studies were smaller, had used slightly different induction regimens that may have masked some of those benefits in terms of mortality. We also had seen at that point that people with slightly less severe kidney involvement should get the same kinds of benefits because they still had substantial risk of progressing on to end-stage kidney disease. At the same time, we asked whether or not a reduced dose of glucocorticoids, oral glucocorticoids, was non-inferior to what was considered a standard dose at the time, and we'll get into that a little bit later on. The plasma exchange, for anyone who does plasma exchange out there, the technical specifications were that we looked at 7 exchanges within 14 days. It was purposely meant to be a flexible schedule in order to accommodate the very broad variety of scheduling in which people were able to work around across the world. We allowed either filter separation or centrifugation, but no double filtration. And the exchange volume was set at 60 mils per kilo. We didn't use plasma volumes as often done in hematology literature or neurology, mostly because the precedent had been set that this was considered a potentially effective dose. And the dose or the replacement fluid of choice was albumin, although plasma was given if people were at risk of or had been bleeding. And everything else we just tried to leave to local practice, as none of it was felt to be particularly important in terms of the biologic effects of plasma exchange. We started off the trial trying to enroll 500 participants in order to accrue a total of 164 primary outcome events. And we're really hooked on this idea that we wanted to get longer term follow-up to really understand how the disease evolved. And so we planned on a minimum follow-up of 2 years at the time. About a third or almost halfway through the trial, we realized that the primary event rate might be a little bit on the low side, but recruitment was going extremely well. And so we made the decision to try and increase the number randomized up to 700 participants. As it turned out, the event rate was not actually low, and it was just that reporting was slow. And so, in fact, we accrued over 200 events in the end of the trial, which is good. We rarely see trials where we're able to accrue more events than we expected. These are the participants we ended up randomizing. So there was 704 participants at the end of trial. They look pretty much like you might expect a group of patients with ANCA-Associated Vasculitis. In fact, they're fairly reflective, I think, of the types of patients that I see. Average age just over 60. Slight male predominance is the disease prevalent, or the disease incidence has a slight male predominance. We saw a slight predominance of anti-MPO, which is expected when we're looking for people with kidney involvement in particular, as there tends to be more severe kidney involvement in the anti-MPO disease. Lung hemorrhage, which had not really been specifically targeted in any prior trial, was about almost 200 patients overall, of which about 61 had what we considered severe hemorrhage, which meant they were hypoxic to less than 85% on room air at the time of diagnosis. Kidney function, so creatinines in the middle range there, about 330 across the trial, and just under 20% who were receiving dialysis at the time, just under 30% who had creatinines over 500. And the therapy, which I think is one of the more contentious things about interpreting the trial today, was very reflective of the era that we did it in. Remember, it was 7 years, and it was starting back in 2010. And IV cyclophosphamide was the single most common agent back then at 50%. And a third of patients still receiving oral cyclo back then, only 15% Tux. If we compare that to today's, the most typical estimate we get across Canadian centers is that somewhere between 50 and 80% of patients are induced with rituximab right now. So what did we see? So our primary composite outcome of death or end-stage kidney disease occurred in 31% of our patients in the control arm, so those who received no plasma exchange. And those who received plasma exchange, crude estimate, just 3% lower at 28%. Survival curves looked like this. Now, if you're a believer of plasma exchange, you focus in on that early separation. There's that sharp vertical uptick at 3 months, and that was where the definition of end-stage kidney disease takes place. So you had to be on dialysis for 3 months in order to meet the definition of end-stage kidney disease. So that's why it's so sharp right there. The most of the line before that, as it's going up with proportion with an event, is actually early mortality. And then you get a slow creep up afterwards, and there's this enticing difference just after the 3-month mark, and then it seems to narrow over time. So we looked at this in terms of several different ways. Our unadjusted analysis, not significant, about a 10% reduction in the primary outcome, but not crossing the line of the null hypothesis. The per protocol population, marginally better. When we censor at 12 months, maybe things look a little bit better. Still not hitting our usual definition of statistically significant, however. Didn't change across any of the subgroups, but I will just draw some attention because it comes back, is to this second last set of rows in which we look at lung hemorrhage, and those with mild or severe lung hemorrhage have point estimates that look quite nice, but with very broad confidence intervals. If we look at other outcomes, death alone, not much effect. End-stage kidney disease alone, and again, this is over the entire trial period, about a 20% reduction, but not significant. Sustained remission, really no difference. SAEs, no difference. Infections, a little bit more common in the plasma exchange group. Quality of life, just the same. So, interpretation. I think the interpretation is often based on whether or not you believe or don't believe at the beginning of the trial. And so if you follow Twitter, now X, there seem to be two groups of people who emerged. There was one who said, fantastic, Pexivas, biggest trial, highest quality data that we have on AAV, neutral across its primary and all secondary outcomes. Plasma exchange is dead to us. We can do without it. Yay. Problem solved. Another view said, that trial's junk. There was no biopsies. 100% of patients didn't adhere to their assigned therapies. Maybe there's even earlier and smaller benefits that you guys just missed. And you only had 100 patients with diffuse alveolar hemorrhage. That's not nearly enough proof to go against plasma exchange in this group. And I would say probably both views are not quite right. As much as I think anyone who does a study and you feel like it's really high quality and you really want to believe in the result, PWR was just one study, and there was an entire very rich history that we were building upon. And so we still felt necessary to perform another meta-analysis afterwards. In fact, this was actually a really important meta-analysis for us, I think, because the information size was now substantially larger. And because we had a very heterogeneous population, it didn't mean that we actually had all of the events that had ever been accrued in plasma exchange versus no plasma exchange in ANCA-associated vasculitis. We only had about half of all of the events. So PWR was important, but it wasn't everything. In this meta-analysis, we looked at individual outcomes. So we felt like there was sufficient power in order to actually look at each outcome individually. All-cause mortality continued to see no substantial benefit. Now, we did this inside the context of the BMJ Rapid Recommendations group, where we had a group of patient partners and clinicians also establish what they thought would be the no important effects. And this didn't cross, this didn't cross the no important effects line in terms of its confidence intervals, its point estimate, in which case they said it is very unlikely that there will be any important effect on all-cause mortality with plasma exchange, and we should interpret this as being neutral. It's always debatable about how confident you have to be around something as important as death, but that's the way that we're going to interpret this for right now, is that there is no important benefits or bad effects on mortality with plasma exchange. So it's a neutral outcome. Those requiring dialysis, though, was a different story. So now we had enough evidence, and this is under a very conservative statistical lens about whether or not there was truly an effect. And it was felt that the likelihood, there is moderate certainty that there is in fact a true effect on end-stage kidney disease at 1 year, and that it was likely to dissipate over time. And so what you're seeing in this forest plot is the 1-year effects. And if we were to show you the extended data, as you get out to 3 years, this effect starts to diminish and it goes back towards neutral. So we interpret this as there is an important risk reduction in end-stage kidney disease at 1 year. At the same time, there was an unexpected but important increase in the risk of serious infections at 1 year, which also diminished over time, although to a slightly lesser degree than one might expect. It doesn't quite fade away as quickly as the end-stage kidney disease component. So at this point, I'm going to say that there is, in fact, with moderate certainty, an important treatment effect that's roughly a 40% relative risk reduction in end-stage kidney disease, and there is roughly a 27% relative risk increase in the risk of serious infections, also with moderate certainty, with no important difference in death. And so if you believe that, you can reduce end-stage kidney disease, at least for a year, which most patients would say is an important period of time, but you increase the risk of infections, we have to try and balance those. And one of the problems is that end-stage kidney disease risk varies dramatically among different patients with ANCA-associated vasculitis. But we're in luck. Silke Brix and her colleagues have put together a very nice risk prediction instrument involving biopsies, as well as clinical data that says that we can in fact predict what the chances of end-stage kidney disease are. You'll notice that in this graph where they've put people at low, moderate, high, and very high risk of end-stage kidney disease, that all the action is right up front. It's like in the first couple of months. And this is exactly what we saw in PWR. Within 6 months, almost all of the end-stage kidney disease data had actually started to accrue or had accrued. And there was not nearly as many cases that accrue after that. It's not zero by any stretch, but the biggest proportion of events is happening very early on, first year at least, and mostly in the first 6 months. The risk score works pretty well. It does require an adequate renal biopsy, which is at least 9 gloms. And it predicts risks over several years, and it works a lot better, though, in that first couple of years, which is exactly what you would expect, that as time goes on, there's all sorts of other things that happen to people. It probably overestimates a little bit in its calibration plots, but it's not substantial. And so there, we have a tool. We can actually now take a patient to the day we diagnose them, and we can say, this is your risk of having end-stage kidney disease. And so if that risk was really low, and then giving extra therapies to prevent end-stage kidney disease may not be all that worthwhile, particularly if they have consequences like serious infections. And if your risk is quite high, then maybe it is worthwhile giving an extra therapy like plasma exchange, and maybe it's worth the risk of a serious infection. There's one caveat is that if you're in a center like ours, we actually don't biopsy very many patients with ANCA-associated vasculitis anymore because the positive likelihood ratio of an ANCA test is so high that we don't feel like there's a whole lot of need. And so we actually spare most patients a biopsy. We only do about a third of them now. But we have another paper in preparation about risk prediction without biopsies based on almost 1,000 patients from 7 trials and over 100 kidney failure events that suggests that if you just take a look at their creatinine and the need for dialysis at the time of diagnosis, you can also estimate. And so this solid line is for patients who don't require dialysis at the time of diagnosis, and the dotted line is for patients who do require dialysis at the time of diagnosis. The bottom is their serum creatinine, and the y-axis is the predicted risk of kidney failure. Now, I like rules of thumb, so I tend to go normal creatinine, really low, 0.2% chance that you're going to require dialysis. Creatinine getting up to 250, so now we're into pretty typical nephrology referral ranges here. 5% chance still only with usual immunosuppression that you'll require dialysis. So 1 in 20, it's not nothing, that's for sure, but it's not all that high either. I'll try and put that in context in a second. When you get into creatinines of 300, interestingly, there is a proportion of patients who start dialysis at around this level, usually in volume overload. And you can get up to a 17.5% chance of requiring dialysis permanently at this time. And if your creatinine is 300 without dialysis, it's down around 7.5. And if you go up into the creatinine of 500, you're looking at 1/3 of those patients who are getting dialysis concomitantly reaching end-stage kidney disease, and 15% if you didn't require dialysis. And you can go up a lot higher. So if you're starting dialysis on someone who has a creatinine of 700, you can see they have over a 40% chance of developing end-stage kidney disease from that event of ANCA-associated vasculitis. So how do we put that, though, into a useful treatment effect? So I really just look at the absolute risk reduction. If you have a low chance of requiring or of developing end-stage kidney disease, then your chance goes from low to also low. There isn't a whole lot of benefit of doing some plasma exchange. If you start off with a 5% chance, so 1 in 20, you go down to a 1 in 33. For some people, that's probably important. For others, it might not be. If you have an 11% chance, it goes down to 7%. And again, now we're getting into, a 1 in 10 chance almost of developing end-stage kidney disease is definitely significant. And being able to get it down to 7%, well, you need to treat 25 patients then to avoid 1 case of end-stage kidney disease. And if you look at these higher risk groups who are now getting into the almost 40% chance, you only need to treat 7 in order to avoid 1 case of end-stage kidney disease. At the same time, how many infections do we cause? We cause almost as many infections, most likely, as we save from end-stage kidney disease. And this is where it really gets into a bit of a trade-off as to how willing are you to risk infections for a shot at getting away from end-stage kidney disease. As nephrologists, I often think we're really bent on trying to avoid end-stage kidney disease. It's like the focus of our lives. And so maybe we don't always pay attention to all of the potential consequences, but they're there. And in our work with patients, they're important too. They really don't want to get infected and be hospitalized. And those who have suffered serious infections, that's pretty bad. If you tell me that the end-stage kidney disease thing is only a 1-year push off, it might temper my enthusiasm to go through some of the other stuff. Before we work with that a little bit further, I'm just going to talk specifically around diffuse alveolar hemorrhage, because this comes up still very commonly, and it's pretty divisive, I think, in the community. We found no benefit on mortality. You can look at the point estimates, but the confidence intervals are very broad, and I have no idea where on the line of very helpful to very harmful they may have laid with all-cause mortality. It is true that mortality is high. It's about 30% in those with severe DAH. So it is a bad part of ANCA-associated vasculitis. If you want to look at more sensitive outcomes, though, in a recent paper that Lynn Fussner published, we did not find any benefit on the duration of ventilation for those. So for those patients who were ventilated, which was actually the majority of those who had severe DAH, there was no difference in the degree of ventilation or the duration of ventilation that they received. And we're pretty confident that the risk of infection increases for those patients, just like it does for any other who treated with plasma exchange. And in fact, that is really the most common cause of death. Unofficially, that was close to 100% of all deaths in the severe DAH group were due to infection. And so I think there should be substantial worry that this is not a benign therapy for patients with DAH. So in the BMJ process, what we said is that commonly diffuse alveolar hemorrhage and kidney and involvement co-occur. And in those cases, you should really base your decision to use plasma exchange on the kidney failure side. The risk of death is high, but if it gets so high that it probably no longer makes a difference whether or not you add plasma exchange and the risk of infection, then it's probably worthwhile. So this is the proverbial kitchen sink analogy, is that you really have to try and do something because the patient is dying in front of you. I would have to say that my experience with plasma exchange as the rescue therapy in these situations has not been great. In fact, we have tried to have a lighter touch on immune suppressing people in many of these cases because the infection risk is so high in them. And in fact, when we asked a group of intensivists to describe the patient that had such high risk that the extra 27% risk of infections wouldn't make a difference to them, they couldn't describe that patient to us. They said that modern ventilation strategies and life support are so good, it's hard to find someone that you really think is that ill, but is not going to die imminently. So if we go back to our two cases, we've got our patient with significant renal involvement and no lung hemorrhage, and we've got our patient with some pretty significant lung hemorrhage, but no really significant kidney involvement. And I would say this is, for me, what kind of typifies how we try and think about it. In the first case, we now go, oh, well, you're at moderate to high risk of you developing end-stage kidney disease. If we give you plasma exchange, it's not a magic bullet. It's not going to take that risk to zero, but it does substantially reduce it. In fact, from a nephrologist perspective, it's like a little bit better than SGLT2 inhibitors in diabetic nephropathy with albuminuria. So it's a pretty potent therapy, but again, it's not going to rescue everyone. And the degree to which we can truly prognosticate is still fairly limited. And so there's a bit of gut feeling there in terms of we think you're going to get better all by yourself or with just standard therapies versus we really are worried that this is going to develop end-stage kidney disease and we want to give it as much of a push as we can. The second case, typically these days, I no longer recommend plasma exchange. We ask those patients not to be transferred in unless there is something else that is happening that mandates that they have to come to an exchange center. Is this reflected in the guidelines? Well, I can speak to the guidelines that I helped develop. Clearly, I'm a little biased, but don't worry, they involved many other people to counterbalance me. In fact, I got no really voting power in this. And we developed in the British Medical Journal this idea that there was a weak recommendation against using plasma exchange in those who had low or moderate risk of developing end-stage kidney disease, a weak recommendation to use it in those who had high risk of developing end-stage kidney disease, and a weak recommendation against using it in those who had pulmonary hemorrhage without any kidney involvement. And it's just important to note, I think, that the way in which GRADE works, a weak recommendation doesn't mean we didn't think that it worked or it didn't work. We're pretty confident in the treatment effects. What it's based on is that the proportion of patients we expect to actually want the therapy would lie between 50 and 70% either for or against, if it's a weak against or a weak for. Whereas strong recommendations were made if we thought that greater than 90% of patients would want the therapy. That got reflected back into the update in the KDIGO 2024 guidelines, where they changed the cutoff from 500 to 300 in the recognition that it isn't that MePEC sits alone and says that it works in people with creatinines over 500, but rather that it works in everyone, but that it's probably only worthwhile in those who have substantial risk of kidney failure. So if we come back to our guidelines, we can see now where the 300 came from. That came from that cut point of about 1 in 10 expected risk of kidney failure. Don't know why the DAH with hypoxemia persists, other than that we now have documented that in fact it is a pretty bad outcome for those patients. I think EULAR has probably got the closest to what we came up with in the BMJ. So checks and X's are nothing official. That's just my interpretation of who is interpreting the data similar ways that we have. In the end, I think, a lot of this comes down to shared decision making and trying to weigh the pros and cons of this therapy for our patients. And so we asked patients during the BMJ process, but there's only a handful that are at the table, and they're usually pretty special people who are highly invested in the disease. So we went out and we surveyed 470 patients internationally. We presented them with the risks of death, dialysis, and infection across a range of plausible scenarios for people with ANCA-Associated vasculitis. And we asked them, given what we expect the risks to go from usual care down to usual care with plasma exchange, would you want plasma exchange or not? And what we expected was that as the risk of kidney failure went up, that the probability of people accepting therapy would go up with it. And there would be some place where we could kind of say there was a cut line of most people really want this. And that would allow us to do something like making a strong recommendation for people with a certain level of expected kidney failure. What we got was this. People value things differently. It was not predictable at all. They don't weigh things the way in which physicians often weigh things. We can critique it as that it's very hard to convey the information in a survey, but I think that actually has been pretty reflective of my life of talking to patients about therapeutic effects in plasma exchange since. And it looks like this in terms of a table. Some people say, no matter what, I want plasma exchange. I don't want to go have kidney failure. Other people say serious infections, no guarantees around the kidney failure part. I never want it. I don't care what the risk is. Some people choose at higher risk, which is kind of what we expected, but it's only about 22%. And some people said we decline it at higher risk, like we really don't want infections. And that was almost the exact same proportion. So I think that really reinforced to us that we need to talk to our patients as best we can, or at least understand what their preferences and values are before we start using these therapies pretty ubiquitously. It does make it really hard to write guidelines. Okay, I'm going to try and do glucocorticoids in 10 minutes. So glucocorticoids, very complicated. Not a lot of data to guide things. I would summarize glucocorticoids as this quote from Colleen Hoover's novel, "I've never loved someone I hate so much, and I've never hated someone I love so much." If you haven't heard of Colleen Hoover, I don't necessarily recommend looking her up. She's a teen romance novelist, which is where this quote comes from, but still very appropriate, I think, for a relationship with glucocorticoids. Why do we love them? They work. This is one of the first controlled studies in ANCA-Associated vasculitis, when it was not even known as ANCA-Associated vasculitis, published back in 1960. And there was basically a 50% reduction in mortality for those who were treated with cortisone at the time versus those who went untreated. That led to a proliferation of as many glucocorticoid tapering regimens as there are physicians in the world, it seemed. And so we sought to try and find a little bit of standardization when we did PEXI-VAS. Very shortly afterwards, colleagues in Japan, led by Shinsuke Furuta, also did a very similar exercise that they called LOVAS. If we line these two trials up, LOVAS, a bit smaller, a bit healthier patients with an MPO predominance, bit more reflective of what they actually see in Japan, which is a slightly different phenotype. And again, we had pretty ill patients that included those with lung hemorrhage and a lot of patients who had either on dialysis or were approaching dialysis. Our regimens were also quite different. LOVAS's, what they called high dose, or what we would call standard dose, was a bit higher than our high dose, but didn't involve any intravenous glucocorticoids. Their low dose group was quite a bit lower, resulting in about a 70% reduction compared to about a 40% reduction by 6 months in the PEXI-VAS regimens. But we both showed very similar things. It didn't make much difference in terms of remission. Mortality and kidney failure rates were the same, although mortality and kidney failure was very uncommon in LOVAS. And the serious infection rates declined in a proportion that was very similar to the proportionate drop in oral glucocorticoids. And so if we go away from the plasma exchange part, instead we look at the glucocorticoids. Sorry, I think I missed my slide up. They generally recommended Pexivast reduced because Pexivast looked like it was a more generalizable regimen across the world and for different disease severities. But what about Avacopan? So obviously, only a couple of years later, the introduction of Avacopan as a different way of sparing glucocorticoids was introduced. Avacopan is an oral C5a receptor antagonist, inhibits neutrophil C11b upregulation, which should decrease neutrophil activation and migration, which is still always, or has been always considered a really key component of the pathogenesis of tissue injury in ANCA-associated vasculitis. And in fact, one of the ways in which we thought that glucocorticoids were substantially responsible for mitigating damage. Advocate was designed as a double dummy in which patients would presumably receive no glucocorticoids once they started Avacopan in the active group and would get a taper to zero of prednisone in the placebo group over the course of about 6 months while receiving background immunosuppression, with a primary outcome of remission and sustained remission at 6 and 12 months, respectively. Of course, this was a tough time to do or not a tough time to do a trial, but it was tough to do a first in-class trial where you're trying to get rid of glucocorticoids, which were the drug that was known to save lives in ANCA-associated vasculitis. And so patients were treated up front with glucocorticoids prior to randomization. And then there was a smattering of glucocorticoids after randomization. So it's never quite as clean as you might hope. If we take a look at the kinds of patients, they're kind of between the low VAS and the Pexivast in terms of disease severity, a little bit lower GFRs, pretty similar kind of split of PR3 and MPO as Pexivast, and no real lung hemorrhage to speak of in the advocate group. If we take a look at the glucocorticoid estimated use and the actual use in advocate ends up being kind of similar to low VAS in the Avacopan arm. So it's kind of a bit of prednisone plus Avacopan versus pretty reasonably high dose of prednisone in the prednisone group, despite tapering to zero. In fact, a bit higher than the Pexivast reduced dose. What did they show? Well, they showed that there was less glucocorticoid toxicity. So that's fantastic. Exactly what you expect. Less glucocorticoids, less glucocorticoid toxicity. What's an important difference in glucocorticoid toxicity? I have no idea. It's suggested that it's 11 based on distributional data, but who knows? It includes such a big catch bag of things that it's pretty tough to tell. I like to look at the SAEs potentially related to prednisone, and you see that it's a number needed to treat of about 13 to avoid 1 SAE. Interestingly, infections not substantially different. So the avoidance of glucocorticoids and replacing it with a C5a inhibitor didn't necessarily reduce infections substantially, despite a large reduction in glucocorticoid exposure. The one thing that I would say is that, I unabashedly love low-dose glucocorticoids. I make no bones about it. 5 milligrams of prednisone seems to actually have a more potent biologic effect than many of us wanted to recognize. And in fact, low-dose prednisone withdrawal may lead to part of this difference we see where you get pretty similar remission at 26 weeks, but then there's a number of flares that happen between 26 and 52 weeks. In fact, it's, pretty reasonable number for only a 6-month period in ANCA-associated vasculitis. So I do worry that this sustained remission at 52 weeks looking superior is a bit artificial for Avacopan. In fact, we previously showed that in observational evidence that 5 milligrams of prednisone does look like it has a pretty big effect, where the event rates or relapse rates go from 14% up to 48% if you withdraw glucocorticoids early. The other thing that's really come out has been, does Avacopan have special effects for the kidneys? Certainly there's some nice biology where complement looks really important in the kidneys in ANCA-associated vasculitis. And you can see here that these gray dots are the prednisone group, where recovery of GFR was less complete than it was in the Avacopan group. That's really intriguing. It's more pronounced when you go to the 50 patients who have eGFRs less than 20 than it was for the whole group, but it looks really interesting. But it's a little bit weird because that's where you get prednisone withdrawal. And if you look at a typical renal recovery curve, it typically goes like this. People just tend to get better for weeks on weeks. In fact, it doesn't really become asymptotic until after a year. So I don't know whether or not that control arm is unusual or the Avacopan arm is unusual, but it's only one experiment, and it's the kind of thing that probably needs to be replicated before you accept it as truth. I just say my experience with Avacopan. So we had the intent of using it in patients who were at high risk of glucocorticoid toxicity. So we listed out a bunch of things locally. It's kind of hard to remember, honestly. And we ended up using it in outside of these quite frequently. And we use it with prednisone. In fact, we've used it across a whole range of things, from prednisone-free induction regimens for people who are really worried about prednisone side effects, to rapid tapers starting at 50 and ending in 0 after 28 days, and to using it as completely adjuvant therapy alongside Pexivast-reduced glucocorticoids when we've been really worried about disease progression. We have had some people who've had discontinuations, usually for GI intolerance. We have had a couple of weird, unanticipated early renal flares. Again, we're kind of on high alert because it's a new drug. And there has been some issues around progressive disease. But again, we do see that on standard of care therapies as well. Thanks to my Otsuka colleagues who just informed me the other day that there is this recent addition to the insert around the possible association with vanishing bile duct syndrome, and that we should be checking liver enzymes before and then every 4 weeks while on Avacopan and clinically as indicated after 6 months of therapy. So one thing to keep in mind. There's still some uncertainties, I think. We really don't understand how we use the two things together to optimal effect. We don't understand what the role of Avacopan specifically in severe disease is, and there's a lot of opinion around it. There's a lot of times when glucocorticoids are initiated and it's weeks to months afterwards that we're thinking about Avacopan instead. And of course, there's these questions beyond glucocorticoid sparing. Do they have other disease manifestation specific effects? So I hope I've left a little bit of time for questions, but my conclusions would be plasma exchange does have a role in preventing dialysis dependency. You really need to consider what the baseline risk of kidney failure is. And as much as is possible, and I know it's difficult, we try and incorporate our patient values and preferences around these invasive treatments that do have serious potential implications. Pexivast-reduced is still the glucocorticoid taper of choice for most patients. You should adapt it if their problems occur, but we don't adapt it in anticipation of problems because we're very, very bad at predicting glucocorticoid-related toxicity. And Avacopan is useful, but I do think we need to think carefully about its limitations, and particularly while it's still a new drug, we need to watch what happens to patients still pretty frequently to ensure that they're getting optimal care, and we should be investing in further research. And with that, I'm happy to take questions.
Thanks, Mike. I'll just get you to stop sharing so we can see people more easily. That was an excellent overview, review, and thoughtful presentation. We do have a few minutes for questions. If people want to raise their hands or put something in the chat, that would be great. Maybe while I'm waiting for that, I'm interested in the shared decision making, and I don't know how easy it is for people to truly appreciate, or what's your experience with people truly understanding when you explain plasma exchange versus something, and does it require a sort of a more sophisticated health literate person?
Yeah, I tend not to go that route. And again, this is my personal approach, is I tend to go in pretty big strokes. So people often have a gut sense about kidney failure and dialysis and how bad it is. And so I try and impart one, kidney failure is pretty bad. And if you develop it, you'll probably regret it. But I don't have any magic treatments for it. I can reduce the chances of you developing kidney failure from pretty high to moderate or low, depending on sort of where they lie. And there is the risk that we're going to give you an infection by doing so, and you have to come in and it's inconvenient. And some people tell me that they go like, oh man, if you can't guarantee that this is going to work, I don't want it because it sounds like it's
Right.
pretty intensive. And other people go, that you just described kidney failure as being horrible. I don't want that to happen. And so I think there is actually a lot of sort of gut reaction to certain areas. Does it mean we get it right all the time? Definitely not. But I think we're doing better than we used to.
Great. Miriam Farah needs to be unmuted. Eamon or Sidoni, if you could unmute her. There she is. There you go, Miriam.
Hi, Hi, Mike. Thanks for all the work that you do on this. I didn't get a chance to connect with you at the recent CAG meeting. A few points just about how we've chosen to look at all the work you've done in this area, and still have somewhat of a nuanced approach. So I totally agree with you about the notion of plasma exchange being that hammer looking for a nail. One of the prototypical nails that we really like is TTP, where we lower mortality with Plex from 90 to 10%. And it just speaks to the pathophysiology of TTP, which responds so nicely and in multiple ways to what plasma exchange can do. And, as you've sort of pointed out, I think ANCA titers, unfortunately, or removal of ANCA antibodies, unfortunately, isn't as straightforward. And we've seen even with anti-GBM that removing those titers rapidly is not as helpful in some patients that we meet too late. The other thing I think that's really interesting is that in your meta-analysis, we have seen trials from the 1980s all the way up to the 2020s, and so much has changed in the last 40 years, as you pointed out with Avacopan and immunosuppression. And you do wonder, how infectious risk is impacted by the choices we make with immunosuppression. And at CAG recently, Mike got a lot of questions about why choose albumin for plasma exchange. Could the results or would the results have been different if we had given everyone plasma or topped them up with IVIG and not made them hypogamma globulinemic, and perhaps they wouldn't have had infection? So lots of interesting sort of thoughts there. But I suppose what we have done here, Mike, is the history is that, when I came on, MePEX was really big. And we were actually plexing a lot of folks in the early or late 2000s or so. And then we did a lot of work to establish that there's actually equipoise about the use of plex so that we can convince ourselves to enroll patients in PEXIVAS. And then we enrolled patients in PEXIVAS and we stopped plexing patients that we typically would have plexed. And we kind of saw, oh, it's kind of the same, actually. And when PEXIVAS came out, I think, we really weren't all that convinced, as you've pointed out. So I was a believer of your trial, and I still am. And I think the meta-analysis has brought out the nuance of evaluating the risk of end-stage kidney disease and the competing risk of infection. But overall, I think, that shared decision-making, as you pointed out, is really difficult with many of our patients. It's sort of like having a code status discussion. A lot of patients don't really know what they're saying yes to, despite all our efforts. So what we've done here, and I'll wrap up, is we have a consensus statement, a provincial consensus statement, and we've actually brought in ICU, rheumatology, both apheresis centers in the province, our GN lead, and of course nephrology. And we sort of have made some recommendations about when we think plasma exchange should be used upfront, and typically that's sort of never. And we've included the idea that patients who are quite sick, whether that's severe renal disease or severe lung hemorrhage, would really benefit being in a center where there's a lot of localized and specialized expertise around, so that they can be evaluated and treated in the best way. So we do bring patients in and think about the kitchen sink approach, but often it's about immunosuppression and more immunosuppression, and perhaps less infection or more infection. And sometimes we do use Plex, but I would say it's really fallen out of favor at our institute. So a little bit of history there. And for my colleagues up on the call, because sometimes this does come up, there is really no difference between being a patient here at our institution versus being a patient anywhere else in the province. We sort of try to stick to these consensus guidelines as much as we can. So a little bit of background of how we've chosen to interpret all the work that you've done. And thank you again.
Thanks, Miriam. Boy, I'm going to have to get you to give the next talk instead. There's a lot to unpack there. The one thing I just wanted to say, though, is that my biggest regret around the way that PXIVAS was published was that it seemed to slam the door for people. And as I got away from the trial a little bit, it's the part of that I regret is that we stopped having some conversations around this. And I think we kind of stopped trying to make rational decisions sometimes. It was just like, oh, the evidence says it doesn't work, so we're just going to completely shut it down. As you said, things are actually substantially more nuanced than that. And we do have to probably differentiate the sick kidney patient from the sick lung patient, from those that have both. And because the effects are different and the goals are different amongst those patients. And so now I'm back to encouraging everyone to just send me a text message or a phone call when they have a new patient and they want to talk about therapy. It also gives me the chance to send them a copy of the reduced dose glucocorticoid regimen so that we try and keep getting that part right. But I really hope that at least we're being thoughtful about when we do or do not use it. And it sounds like you guys are. It really is a matter of just trying to apply the evidence in its most nuanced manner now to the patients in front of us.
And the point about the heterogeneity of the outcome that we're looking at, I think, is something that did get missed and is really worthwhile reminding ourselves about.
Yeah.
There's one question in the chat that we have a minute to do if people are still on. I want to congratulate you for having over 94 people on at one point in today's session. So that's great. One of our records for this year. Patients that you worry about with low dose glucocorticoid, rituximab use for induction.
Okay, so this is very apropos because there was a paper published, I think now 3 days ago, with the French experience on rituximab and other regimens and what they called low dose versus or reduced dose versus standard dose glucocorticoids. I actually have a whole bunch of slides about this because it's become such an issue of trying to describe. I would just say, if you look at that data very carefully, it is not PXIVAS reduced versus PXIVAS standard. It's not even close. It's a very different set of regimens. It's observational data. It's at high risk of bias and it's imprecise. And they've tried to compound a bunch of outcomes that it doesn't necessarily make sense to compound. And in fact, we've looked at individually across PXIVAS and it is neutral. It's either neutral or beneficial to have low dose glucocorticoids. And that's why I always say, start off with PXIVAS reduced. If you encounter a problem, you can change the glucocorticoid dose. And in fact, for most of us, if you're going to encounter a problem, it's going to be in the first month or so. And that's when you can adjust course. So monitor carefully, try and avoid the harms of high dose glucocorticoids. And then if you need them.
Right. Well, again, we're a little bit over time, but thank you very much for excellent overview and for reminding us that randomized controlled trials still even if you think it gave you an answer. So I think that's also really a worthwhile Friday morning takeaway message. In addition to looking carefully at assessing individual risk, not just slamming them with everything. So thank you, and thanks everyone for paying attention. And for the 97 people that were there at the beginning, you still have 63 listening. So that's pretty amazing. So thank you again for making the time, and happy Friday,
Thanks so much, everyone.
everybody.
Sorry about going over. Bye-bye.